thank all of our witnesses for being here today. You know, since the COVID-19 pandemic, I have really been pressing for more NIH funding to help us better understand and treat long COVID, and I continue to fight for strong funding bills for health research and public health infrastructure as we are now negotiating our current funding bills. Last Congress, I fought very hard to pass my Prevent Pandemics Act to make sure that we would not be caught so unprepared for whatever the next pandemic hits. But there is a lot more that we need to do. As all of you well know, we need better information, we need better care, we need better treatment, we need better public awareness to help with prevention. And I know for patients dealing with this, long COVID is a serious life-altering condition and one we are, as many of you just said, learning about every single day. So I really appreciate all of you being here and sharing your stories. You know, throughout the COVID-19 pandemic, we know that women were likely to be exposed to COVID-19, frontline essential workers, our daycare workers, our nurses, and many of them living in underserved communities. Now, I believe in general that our country needs to take women's health more seriously. So I think this question I have for you is extremely important. Given the barriers women already face in getting quality care, what are some of the unique challenges you all may have seen as women seeking care and treatment for long COVID complications? And Ms. Vasquez, I'll start with you.
Yes, I absolutely believe my gender and my ethnicity played a role in not being able to get care, especially at the beginning of the pandemic when hospitals were absolutely rationing care, even if it wasn't an official policy. I was told multiple times that unless I was elderly and in need of a ventilator, that I needed to go home and save beds for people who were really sick. And this was after getting labs showing that I was severely blood clotted. I was told that that was a false positive and that I didn't actually need any care. I was sent home as a psych patient. That continues to happen to women, especially women of color, Black women especially. And I kept going back to the emergency room because I told myself, I am not going to be a statistic. And I think, unfortunately, those statistics are growing.
Ms. Beal?
Thank you for your question, Senator. For me, early on, I did have a doctor that kept saying that it was just depression and anxiety. That's why I was achy. That's why I was tired. It's just depression. It's just anxiety. You know, go see a therapist. Let's work on it from that angle. And that's very discouraging as a woman or any patient, that it's all in my head. You know, I know it's not all in my head, but this doctor is trying to make me feel like it's all in my head, and it's very discouraging. You know, there were some instances where I requested some testing, and there was a little bit of pushback on that. You know, and I think that was coming into play of, you know, the woman being a woman and I guess kind of brushing me aside a little bit more. One of the things I needed was blood work to test my ferritin levels, and the doctor kept testing just the iron, but it's separate tests. And I found out that I was anemic. But if I hadn't kept pushing that with him, I wouldn't have been able to get that conclusion.
Yeah. Ms. Howell?
I don't think that's something I can really speak on for my daughter.
Okay. Well, let me ask you about access, because a lot of patients with COVID, long COVID in my state of Washington have told me that they have really limited access to quality treatment and rehab services. The University of Washington's post-COVID rehab and recovery clinics is one of the few that we have in a very large state. I know you all have lived through the challenge of navigating our healthcare system. What do you want to see done at the federal level to expand access to quality care for long COVID patients? Any of you? Ms. Vasquez?
Yes, I really feel like we need to broadly disseminate sort of basic diagnostic and screening tools to, again, primary care physicians. They are the front line. They're the first person that folks go to after an infection with these, somewhat nebulous symptoms. These conditions have existed. We have clinical diagnostic tools to be able to diagnose and then manage these conditions. That needs to be disseminated widely. And I think there's also a role to play through HHS and guidance to state Medicaid agencies to really hold contracted managed care plans accountable to identifying and treating long COVID adequately.
Okay, very helpful. Either of you want to comment? I am out of time. I wanted to ask Ms. Heim very quickly. We know that the education system during COVID, a lot of kids suffered. We're still dealing with a lot of the significant impact of learning throughout that time. Your daughter's now, how are you educating her with long COVID? Is that a challenge still for parents?
We had transitioned from in-person school to a homebound program, which most states have, but even that was too much for her to be able to do with the anxiety, the 4 core classes, and they had tutors that would meet with them. But a lot of the teachers weren't cutting her any slack. They weren't, giving her less work. They weren't sympathetic at all.
Well,
And
we're dealing with learning loss from COVID in general, and I think we need to highlight it with long COVID patients as well, especially young kids. So thank you.
Senator Cassidy.
I will defer to Senator Braun.
Thank you. When I look at what we do here on this committee, I think whatever the particular topic